Good day, everyone. My name is Lauren Magluyuan, and today I will be presenting to you one of the anxiety disorders, which is the post traumatic stress disorder. Let's first define anxiety. Anxiety is a universal human experience and is the most basic of emotions. It can be defined as a feeling of apprehension, uneasiness, uncertainty, or dread resulting from a real or perceived threat. And there are levels of anxiety: mild, moderate, and severe. Mild is a normal experience of everyday living. It allows an individual to perceive reality in sharp focus. Moderate is as anxiety increases, the perceptual field narrows, and some details are excluded from observation. So, in moderate anxiety, the individual sees, hears, and grasps less information and may demonstrate selective inattention, in which only certain things in the environment are seen or heard unless they are pointed out. In severe anxiety, perceptual field of a person experiencing this is greatly reduced. One may focus on one particular detail or many scattered details and has difficulty noticing their environment, even when it is pointed out by the other. So learning and problem solving are not possible at this level. Now we proceed to the main topic of this presentation, which is the post-traumatic disorder. Post-traumatic disorder is an acute emotional response to a traumatic event or situation involving severe environmental stress. An individual with PTSD persistently experiences a traumatic event that involved threatened or actual death or serious injury to self or others, and to which the person responded with intense fear, helplessness, or horror. So, PTSD may present after any traumatic event that is outside the range of usual experience, such as the military combat, detention, natural disasters such as the flood, human disasters such as plane or train accidents, crime related events such as sexual abuse, and diagnosis of a life threatening illness. Anatomy and physiology of the brain related to the PTSD. So it involves the amygdala, which is the brain's stress evaluator and decides when to react. So when a traumatic event occurs, the amygdala sends out a danger signal, initiates the fight or flight response, and stores the stimuli associated with memory, such as the sights, sounds, and smell. And signs and symptoms associated with the amygdala are anxiety, hypervigilance, exaggerated tendency to be easily startled, and excessive amygdala activity. After that, the hippocampus is essential to the memory formation. So, when there's a traumatic event, the hippocampus creates and stores the memory, retrieves the memory, and calms the amygdala alarm circuit. Signs and symptoms associated with this is confusion, disorientation, recurring thoughts, nightmares or flashbacks, difficulty sleeping, or reduced size of the hippocampus. And then the prefrontal cortex, which lies directly behind the forehead within the frontal lobes and controls the behavior, emotions, and impulses. So after a traumatic event, the prefrontal cortex should let the amygdala know that it is okay to calm down once the danger has dissipated. Signs and symptoms associated with this is irritability, withdrawal features such as numbing or avoidance, and reduced activation of the prefrontal cortex. Now we proceed with the patient profile of someone who is having PTSD and is nearing discharge. So this patient is Mr. Gary Smith, a 30-year-old male coming from the First Nation of Métis and lives in Regina. Gary lives at home with his parents, and this disorder is a new onset. History would be the patient served in the Canadian Armed Forces during the war in Afghanistan, and few of his comrades died of bombing. 6 months after the war, patient has been having nightmares, irritable, and verbalizes plans of suicide. Comorbidities known would be the patient was known to be alcoholic, and patient has a supportive family and friends, but the patient feels estranged from them. Nursing process. So, in this kind with this kind of patient, nurses must make sure to use therapeutic communication. Stay, for example, Gary stated that I don't deserve to live. I should have died with the others. The nurse should respond in an exploring way by saying, "Tell me more about it. Is this how you feel every time you remember the incident?" And then when Gary replied, "I don't want to talk to you or anyone." So the nurse should respond in a way that she verbalized the implied, which is, for example, "Do you perceive that no one understands?" So it's very helpful to use a therapeutic communication for us nurses to develop trust and establish rapport towards our patient. Nursing diagnosis: risk for suicide related to anger and hopelessness due to severe trauma, as evidenced by suicidal plan and verbalization of intent. Another is fear related to perceived danger, as evidenced by hypervigilance and agitation. Our treatment goal: the client will establish a safety plan with the nurse, including the identification of triggers, coping strategies, and emergency contacts. And patient will openly discuss fear and what is invoking the sense of fear. Our nursing intervention here: we should encourage patient to agree with the safety plan and to talk with the staff when experiencing suicidal ideation. And then we also need to interact with the patient at regular intervals to convey caring and openness and to provide an opportunity to talk. So in this case, our evaluation are both goals are met. So after 8 hours, the patient agrees to safety plan every shift and starts to discuss feelings of self-harm. And by the second day, the patient occasionally answers questions about feelings and admits to anger and grief. Our treatment outcome here is that the patient has shown consistent refrain from attempting suicide, and the patient was able to pinpoint triggering factors and able to develop coping mechanisms such as deep breathing or distractions such as watching TVs or listening to music. Our pharmacological interventions would be SSRIs. Example of this is the fluoxetine or Prozac. So relevant patient teaching with this medication: it should be taken with or without food, and it should be taken same time every day. So it may take 4 to 5 weeks or longer before you feel the full benefit of fluoxetine. Continue to take fluoxetine even if you feel well, and do not stop without talking to your doctor. If you suddenly stop taking this medication, you may experience withdrawal symptoms such as the mood changes, irritability, agitation, dizziness, numbing or tingling in the hands or feet, anxiety, sweating, confusion, headache, tiredness, and difficulties falling asleep or staying asleep. So your doctor will probably decrease your dose gradually. Patient resources. So by the time that the patient will be discharged, um, he should be aware of resources outside the facility that can help him recover, continue to recover in a daily basis. So he is able to contact either one of the following: the Healing Through Humor, Grief and Bereavement Mental Health Support, and Support Services, Recovery, Rehabilitation, and Reintegration, which is provided by the Government of Canada. And there are numbers and websites included that the patient can dial. So, crisis intervention would include the Mobile Crisis Services, which is located in Old One Firewall Park, And the address is 1646 11th Avenue in Regina, and has a phone number of 306 757 0127. And that's it for my presentation. I hope that you have learned something out of it, and I hope you have a great day, everyone. Thank you.